Good morning, everyone. My name is Carolina Lucy. I'm the Associate Director of Programs here at the Institute. It is my pleasure to guide you today through the programming. We're going to start today with a very timely conversation around priority setting, solidarity and global justice when resources are scarce. This session is a collaborative effort with our partners at the Department of Global Health and Population at the School of Public Health. And to open this dialogue, we will welcome Ole Norheim, who is the Mary Saltonstall Professor of Ethics and Population Health here at the School of Public Health. Professor Norheim, please join me here. Thank you.
Thank you so much. And I think this panel will follow very nicely after Dr. Nishrat's very thought-provoking thoughts and talk. So I want to reflect a little bit on the moment we are in now as a global health community. And I make 3 points, and I'll start with macroeconomics. The latest Financing for Sustainable Development report from 2026, the UN Interagency Task Force, concluded that the poorest, worst off countries are in a financial squeeze. Structurally low tax revenue. It hasn't changed for 20 years almost. Decline in official development assistance, as we have heard a lot about here, and trade and investment disruptions. And the latest war, of course, in the Middle East has made it even worse. So on the ground, clearly budgets will be cut. And that's what we will discuss in this panel, and what countries can do and what global actors can do in response. And to help us with that, we have the Lusaka Agenda. This was chaired by the government of Kenya and the government of Norway, chaired by Jon Arne Røttingen and Mercy Nyeru from Kenya. And it actually started in 2023, before this latest crisis. So there's been thinking, fortunately, around this issue for a long, long time, and the need to reform the global health architecture. And I'll not summarize the recommendations, but the key message I would say is that we need to discuss and reform the way we support countries, not bypassing them, but the direct support. It's all about shifting the power balance to the national level, supporting countries with decision-making, policy and planning. And that leads to my third point, priority setting, values, and the ethics of priority setting. Because we have always had scarce resources, we have always had budget constraints, and we need to have this discussion. What should country do? What should they invest in? What kind of services to provide? Which groups of patients to protect? And my ethics is quite simple. I think priority setting should aim to maximize health impact, financial risk protection, with extra priority to the worst off. Not everyone agrees with that, but we need that discussion because we always need to make and set priorities, choosing within constraints and now even more extreme budget constraints. So I'd like to welcome the panel. Maybe you can start coming up on the scene, starting with Dr. Addis Tamira, who is Senior Director of Integrated Health System Strengthening at AMREF Africa, Ethiopia, and now Acting Director for AMREF Ethiopia. And he's working on implementing primary care services on the ground. Next, Calypso Chalkidou, who is Director of Finance, Performance, Finance and Delivery at WHO. And Jon Arne Røttingen, who is CEO of Wellcome Trust, and one of those who had the initiative for the Lusaka Agenda. And to lead us through this discussion, we have Joya Mukherjee, Chief Medical Officer in Partners in Health, and also Associate Professor of Global Health and Social Medicine at Harvard Medical School. So over to you.
Great. Thank you so much, Ole. I'm excited to have this conversation with all of you. I think you all bring very unique perspectives. And I agree that following Dr. Nischar's excellent summary of where we are, I think when we think about priority setting, the idea that was hatched at the Future of Global Health Initiatives, or the FGHI, that came up with the Lusaka Agenda, is a very important thing to revisit. So I'd love for all of you to start with your perspective briefly on what are the external and internal drivers that you see right now in global health. So Addis, why don't we start with you?
Yeah, thank you very much. Thank you very much again for this opportunity to basically speak on this very important point. And I think that we are at a critical inflection point where the core challenge in global health is not basically no longer identifying what works, but deciding what to prioritize when we're not able to fund like everything. So that basically takes me to the point that who should be like setting priorities and actually we believe that formally governments or countries set priorities, but in practice priorities are co-produced and often fragmented by lots of internal and external forces. So externally vertical programming, donor earmarking, global health security agendas basically drive the decision making, and internally priorities are basically driven by fiscal space, the political economy realities, and institutional capacities. So in many settings across the continent in Africa, where I come from, priority setting is less about making the optimal choices, but rather about navigating constraints imposed from inside and outside the system. So that's exactly, we were talking about the Lusaka Agenda earlier, and that's exactly where the Lusaka Agenda comes in, calling for a shift to a country-led, integrated, evidence-driven prioritization by countries, while partners basically rallying behind national-led systems.
Thank you. Calypso, I'd love to hear your take from a WHO perspective and what you're seeing in countries where you support.
Yeah, I think it very much depends on the money, really. Mm-hmm. He who pays the piper calls the tune. And I think, so let me give you some numbers, right? Let's talk about the poorest countries that Ule mentioned, were referenced in terms of the macro-fiscal squeeze there, Andrew. So in the past 15 years, out-of-pocket spending grew faster than domestic public spending on health. The past 15 years. So out-of-pocket, households, the poorest people spending to access care when they can afford it. Many can't. This is the most inefficient and most inequitable way to finance a healthcare system. That was the fastest growing element of spending on health across low-income countries. Domestic public spending grew during 2020, during the pandemic, and then declined. So now we're back to where we were in 2010. So this is 15 years of basically no growth at all. And the health priority that governments put, the poorest governments place on health as a proportion of their domestic budget is hovering around 6%. And the Abuja target that countries came together and agreed to is around 15%. And in fact, domestic spending on health lags behind both out-of-pocket spending and development assistance in the poorest countries in the world, the low-income countries. So priorities in these countries are very much set by the parliaments and by budget cycles and by advocates. and effectively by mechanisms of allocating budgets in wealthier countries still. And that's why I think the Lusaka Agenda was quite topical, because it tackled this particular question. And now the question is, of course, what happens next?
What happens next? Jan Arne, you were the co-chair of the process that produced Lusaka. So maybe you can, summarize, given what Adis and Calypso have said, how is the Lusaka Agenda moving us forward, as Dr. Ivers commanded us?
Good idea. Good set of directions, no willingness to implement. I think that's the...
I hate when that happens.
That's very common in the academic community, and it's great to be back here at Harvard, and actually the collaboration between the two sort of affiliations I had when I was here as visiting and then later adjunct professor. Maybe briefly, the driver of the Lusaka Agenda came both from in particular the African continent, feeling left behind and really doubling down on language around health sovereignty, aid independence, having their own means in manufacturing and maybe with the wrong focus, because vaccine is the hardest by whole sort of commodity to produce in many ways. So that was a strong voice. And then the other process where I came more from, because I was then Global Health Ambassador of Norway, I had led the coordination of resource mobilization for the pandemic across vaccines, therapeutics, and diagnostics, and PPE, the ACT Accelerator. And where the donor governments were really pleased with the fact that finally we had a common platform to actually discuss allocation of resources across the different institutions, the global health initiatives, but also the WHO, even though we didn't influence the World Bank, but at least there was a clear communication with the World Bank. So there was sort of a drive from both donors and what we can, still that dichotomy, the recipient countries, to have a common process and conversation. And the direction was very clear, and we heard it from Ole as well. It is about countries deciding priorities. The challenge is that there are two systems of accountability. It's the political accountability in the recipient countries, and then it's the political accountability in the donor countries. And where the resource mobilization, and I think US is the most sort of clear-cut example of that, it goes to very specific health outcomes or technologies or diseases. That's the easiest way to mobilize resources. And how do we square that dilemma? And just I led a global health financing working group at Chatham House now probably more than 10 years ago. A real basic basket of healthcare for everyone is maybe costed around $100 a year, and that's still a basic basket. If all countries spend at least 15% of general government expenditures or 5% of GDP, and it depends on their tax income opportunity, there is still a lot of countries that would not be able to meet $100 per capita per year. And the challenge is that if you cost that up, it's more than $100 billion. It's way above what we ever do. And then, so the money is a problem, and who are accountable for that problem? And then you would say, should we then take a zero budgeting approach, which we in a way have done for AIDS, TB, malaria, and decide we will fully cost these interventions, and we will have programs to deliver them to eligible countries. We will do the same for vaccines, fully cost them, and then have some copay and all of that. Or should we leave that sort of prioritization dilemma to recipient countries? I think we haven't decided on how we will do that. I am very much leaning towards we need to actually give that responsibility to countries, because health is a political fight. It's a struggle.
Sure.
You need to have the politicians need to be accountable. You need to have those discussions in countries. You need to mobilize taxation and reduce illicit financial flows, and that the politics is local. Politics is domestic. There's no global political system in that sense, and even less so than ever.
And I think you bring up such an important point, which is this notion of sustainability. What is actually sustainable on the scarce resources of countries? And if, is it okay to say country X has $20 and that's the best they can do, and country Y has 120? And I think we will continue with the inequities if we do that. And I think when we, Ole mentioned the idea of financial protection for the most vulnerable, that is going to mean, for equity's sake, to resource the poorer countries and the poorest communities more. Adis, maybe over to you.
Can I just
comment
yes,
briefly? Of course, yes,
Sonja
please.
didn't want to define global health. So I actually I Googled and I looked what is the definition of global health. And one definition is global health equity.
Yes, yeah.
Which is a very expansive definition. Yeah. Then last night I was in a dinner in DC, including with the former health ambassador, or global health security ambassador of the United States, John Nkengasong, and he said, there is no such thing as global health. If we want to talk about global health, we could potentially talk about global health security, which is a common challenge, and then risk norms and standards. But otherwise, health is local, national, and we need to accept that. Those two perspectives are really different.
Really different. Yeah.
And I think the global health equity part is not high on the political agenda in almost any country currently. I think that's the reality of the world, really. There's really low level of solidarity. We should fight that, but that's still the political reality.
Yeah. And I'm a moderator, so I will refrain from putting in my opinion. So over to you, Adis. The Lusaka Agenda calls for this increased domestic resource mobilization. You're at AMREF, but you've also worked at, in the Ethiopian Ministry of Health as Chief of Staff. How do you see that domestic resource mobilization at a country level, given all of the competing challenges of what's happening in Ethiopia and elsewhere? Who will pay for the health? Because as Calypso reminds us, it's not that nobody's going to pay for it. If the government doesn't pay for it, if donors don't pay for it, it comes out of pocket. So what is your perspective on that as a real possibility?
Yeah, so I think it's important that we're basically addressing two important things. One, answering the question who pays is incomplete without properly addressing what do we mean by sustainable. So I don't think that everybody is on the same page when it comes to sustainability. Some believe that sustainability may be interpreted as full domestic, financing in the short term, which is not actually, realistic for many African, countries. So sustainability should also include the ability of countries to basically prioritize, allocate, and use resources for their own, national priorities and interests. And in fact, there has to be accountability attached to that. So to be able to do that, countries may probably need to have three important things, I would say. One is the prioritization. That's being explicit about what's basically funded, and the efficiency and integration is also critically important. Moving away from fragmented vertical programs towards systems that can deliver multiple outcomes with the same amounts of resources. And third is the redefined partnership model where the external financing is properly utilized. Dr. Nishtar was saying that external financing is not going to disappear 100%. It's going to be around, but making sure that is playing a more catalytic role and is more aligned and is more supportive of the national priorities rather than further fragmenting them is very important. So for me, sustainability is less about who pays in absolute terms, but more about how intelligently we prioritize, align, and use the resources we already have. So in that sense, sustainability is not a financing endpoint, but it's a discipline of decision making under constraints.
Yeah, that's a really interesting perspective, the idea of discipline and where the priorities are. And that really leads me to ask you, Calypso, in your role at WHO and looking at things like performance-based financing and how you improve delivery. The Lusaka Agenda puts the WHO in a bit of a driver's seat there in terms of harmonizing frameworks and tools. How do we support that at a country level?
Yeah, thank you. I mean, if I may again cite some figures.
Please.
I think it'd be good to zoom out a little bit. So, I think countries need to spend more, and as you said, it's very much about how the money is spent. There's a lot of efficiencies and to be had and better distribution of the resources, however little money there is. At the same time, however, especially the poorest countries are operating within a structurally unfair system.
Yes.
So there's some embedded inequalities in the global financing architecture, which make it very difficult for very poor countries to grow themselves out of poverty and find that additional money that is needed to invest in their own population. So, for example, in 2023, Africa received $74 billion in aid across all sectors, and it lost twice as much to illicit financial flows and corporate tax exemptions. And it takes two to tango, so the money went somewhere towards the north.
We know it has gone.
Right. So that's one thing. Africa, on average, spends twice as much as a fraction of their gross domestic product, on average, on servicing its debt than it does on health and education together. So, and these things are getting worse because the IMF is deeming countries not to be poor enough to default, so they should continue servicing their debt. And that debt eats into the fiscal space countries are able to allocate towards health. So I think we need to remind ourselves when we talk about domestic financing, we need to talk about international taxation and tax rules, and we need to talk about debt. Otherwise, it becomes a little bit problematic just focusing on specific interventions and technology. On what WHO is doing, well, I mean, we've had a lot of requests from countries during this health financing emergency, really, because I think it is really an emergency with support requests on how to prioritize. And I think that's quite important because priorities are being set by default because of the financing decisions made, whether at national capitals in recipient countries or here or in DC or London or Geneva. The question is, are there explicit priorities? Can the trade-offs be quantified and elevated? So who's losing, who's winning from those decisions or not? And usually they're implicit priority setting process, and that's why it's important to make this explicit. So our work is very much on the process side, and we very much look forward to working with Ule and his colleagues here at Harvard as well, looking at priority setting processes and the analytics that come. So as these decisions, these choices governments make, what to allocate, what are the opportunity costs and who bears these opportunity costs, developing tools to help countries make these decisions on costs, and also trying to plug these priority setting processes into budgeting processes so that once a government prioritizes something, then there is a process through which the money actually follows through. Budget cycles, midterm expenditure frameworks, so bringing the two together, ministries of health and ministries of finance. So I think that's a big gap and it's quite important.
Great. Thank you so much. Jan Arne, I'm still gutted by this idea that there's no global health. So I'm gonna ask you to go into, since you were there framing the Lusaka Agenda, the idea of national sovereignty and what does that mean. I want to understand a little bit more. I'm going to go off script. Sort of how the ideas of debt and tax flows and all of the resources going out of Africa to the West, how did that play into these discussions around sustainable health financing? Because even if governments do more, they are so constrained. So what is your sense of that?
So I should be honest and say that that did not play a big role in the Lusaka Agenda process, partly because it was really driven by health people in a way, both from in particular Africa and also from those involved from donor countries. I think a big challenge, and actually in my country we tend to say you can meet yourself in the door in a way. You have some principles, and then when you try to apply them, suddenly you get them up in the face really directly. And so I'm definitely in proponent for sort of countries need to decide, make decisions, prioritize, do the explicit trade-offs, and consider. So in a way, that means de-earmarking some of the clear ambitions from donors and willingness to come together. There are potentially some exceptions, and I think the worst of sort of exemption, the key population marginalized groups, there are human rights sort of arguments that we could, with sort of solid foundation, use. But then, sort of, if you follow that, so what? And I'll get to your question, because should we then? Why should we then even earmark to health? Why? Because in a way, and that's where I am struggling, because I'm a physician. I care about health. I see that countries under prioritize health, but that's really the key, because in a way, then we only, in a way, at least talking about the balance between domestic and international, in a way you should allow it for countries to decide, and so there should be a general development finance instrument, and they should allocate resources to sectors, and in a way they have been doing that, because there's solid evidence on crowding out domestic finance because of the very strong impact the global health grant financing has had on the opportunity to finance health, and then governments decide to reduce their own domestic finance. That's a decision in ministries of finance, and they finance other sectors. But the challenge, so in a way, then we go back to the era before even we had dedicated big grant funding mechanisms, or before the year 2000, as Sonja alluded to. And of course, these were created because we were not happy with let's say, the World Bank and the development banks as the only finance instrument. And that is then linked to the debt. So should we only solve this on the sort of financial flows and the international financial system? No, I don't think we should, because I think we should be drivers for, in particular, making sure that human capital and sort of the human social phase of development is high on the agenda, sufficiently high. And we have history demonstrating that countries do not prioritize this. And in particular, when it comes, and probably their instruments that they negotiate with, the development banks do not prioritize it, because the return on investments are too far away.
Too far, yeah.
And so we see it now. Actually, the portfolio on health projects in the MDBs, including the World Bank, is going down instead of going up. And they invest in energy, in critical minerals, in transport infrastructure, in digital infrastructures, and if health, it's tertiary hospitals. So I am then, I am for...
You're meeting yourself at the door.
Exactly. I am for earmarking to some extent, or incentives at least, on making sure that countries are incentivized to use some of the external finance for the health sector. But that needs to link to...
But I think there's two fallacies, if I may, what you're saying. So the first thing is you're confounding health with TB, HIV, malaria, and vaccines.
No,
well, about
I'm not.
3/4 and more of the grant money that went to health through these global health initiatives actually went to these things.
Yeah, but that's the...
It went to these things during a time of emergency, and it should have gone. But then it continued flowing to these things during a time was not an emergency. And so we've lost the idea of systems, because it was hard to grasp, I guess. And WHO is also responsible. What is a health system, and does it return?
My point is that earmarking to health is not necessarily earmarking to single diseases.
It's not, but we made it be that over the past 20 years, because we've channeled health aid money through vertical channels. And as you say, there's quite good evidence that this crowded out government investment, not just in these specific disease-specific and technology-specific and population-specific areas, but crowded out money towards health.
Yeah. And it increased the willingness to invest in health in donor governments. I think that's the big challenge. We don't have a defined envelope of money we can maximize use of. That envelope is dependent on how we structure the system. So it's an interdependency here that is so hard to reconcile. And in the US, that's decided in Congress, really. Bipartisan leaders coming together, let's now go.
With a lot of support from civil society.
Of course.
And we're going to talk
but
more
the
about...
second problem is that grants also have an opportunity. So IDA, for instance, can range from fully grant, long maturities, very low interest rates, effectively it's a grant, all the way to concessional towards high street rates when we head towards IBRD. Grants channeled by the government of Norway through the Global Fund. Okay, Norway is a wealthy country, have a surplus. Let's take another country, let's say Greece. Very little money, yet contribution. This is usually borrowed money, right? So there's an opportunity cost there. So I think we need to move beyond this sort of dichotomy between this is purely grant and this is purely loans, and grants are good and loans are bad. Yeah. So I think going back to the macro fiscal and looking at what treasuries are doing is quite important. Ultimately, we need to accept that countries will have to make some decisions. All we can do is put the evidence out there and push for a pro-poor, pro-health policy. And then if we're going to walk the talk, then we need to step back and stop distorting the global.
Before I go back to you, Jan Arne, I'm going to bring in Adis for a second, because I think what Calypso is saying about these vertical financing being sort of driving the agenda, maybe we've all seen that to be true. However, I would say in my own experience, working in many countries in Africa, many governments smartly used those vertical monies to develop very robust systems of primary care. And especially in that first, let's say, 10 years of GHIs, a lot of the money wasn't for commodities because we didn't yet have those people on therapy. And that money went into, can you
I think Ethiopia,
confirm or deny for Ethiopia?
Yeah, I can do that to some extent. I think Ethiopia is a very good example of that.
Yeah.
Whether it's the Global Fund for AIDS, TB, malaria, Gavi for the vaccines and so on, the other instruments, Ethiopia has been receiving this vertical funds, but it has smartly basically used those resources to build its systems.
Yes.
Like look at the data systems, the supply chain systems, HR and everything. And I think through time, this different mechanisms have learned that having a window attached to it, HSS window, would be helpful. And I think they have come up with this idea of having a window attached to this different funding mechanism. So definitely, it's ideally you would want to have unrestricted or unearmarked funding, so that you are able to have your own priorities defined and able to support your own priorities with those kinds of funds. But if that's not the case, you should not be wasting your time, pulling all those arguments that it has to be this way, it has to be that way. At the country level, once you are very clear about your priorities, what you need to do with the resources, then you can stretch every dollar actually to basically make sure that the requirements are met on one side, and then you are able to build your systems on the other side. So I think multiple countries in Africa, including Ethiopia, Rwanda, and Zambia, Malawi are very good examples, I think. Yeah.
Thank you. Jan Arne, you wanted to jump in here.
Yeah, I should probably be honest to talk a bit about the opposition against the Lusaka Agenda as well, because you mentioned civil society. So the main opposition, the clear opposition, was from the chief executives of Gavi and the Global Fund, just to be very open. And they wrote letters to me, and they were not nice letters.
And why? Tell us a little bit more about why they would be
of course,
opposed.
because they were afraid of this would undermine their ability to mobilize resources and actually be dedicated and on their mandate and get sufficient funding for agendas that are really important and also still not fully funded. So I'm not criticizing their motivations. Yeah. It's a good incentive.
They were sort of in favor of staying more with the vertical for resource mobilization.
Yeah. And then playing lip service that say that, but we do coordinate and are coherent at country level, and we have country coordinating mechanisms. We follow national plans. And then you check with the government of Malawi. I was in Malawi 3 weeks ago. They needed to have more than 50 different national plans, because the plans needed to adhere to the needs of the different donors. In Ethiopia, what I heard from Ethiopia recently is that they have more than 200 contracts or agreements with external funders. yes, that is, you can maximize, with good leadership, you can maximize the use of that, but it creates a big
huge burden.
It's a headache.
The burden,
system.
yeah. The
But I should say
burden.
that the strongest opposition against the Lusaka Agenda discussions were really from civil society.
Okay.
And
why do you
advocates.
think that is?
No, because we have organized, in particular in the global north, organized civil society to be advocates for the diseases and the technologies we think are important. And this is probably even most on the global fund agenda. And in a way that's great, because that was also the AIDS movement in particular was the driving force for establishing these instruments. That was the driving force for expanding the financial envelope for health aid, which is great. But then, as I said, when you then take disease by disease, zero budgeting, any attempt to reduce that, any attempt to reduce the number of countries eligible for global fund support to concentrate in the poorest countries where there are really big needs, will have opposition from that civil society advocacy.
Yeah.
And the US is full of these organizations, and they have been funded well by philanthropy. And they go into DC and lobby Congress, and there is a machinery sort of that is built to just make this system sustained. I don't think that is wise, but so I said to another big foundation, that you have created this problem, you need to fix it, because they fund it.
Interesting. Very interesting. I'm going to pivot a little bit to talk about something that was also mentioned in our keynote about sovereignty in terms of R&D. And how do we get the tools when we look across the big gaps now with the US changing their tune? A lot of it is around commodities, around drugs, diagnostics. So now you are the head of Wellcome Trust, and the Lusaka Agenda does call for coordinated approaches to R&D, manufacturing, market shaping. How do you see that as a way forward toward sovereignty?
Yeah, and again, a moment where I meet myself in the door, because and here it's in principle there are some principles here that actually do collide, because the research and development agenda, in particular when it comes to technologies and so new medicines, new vaccines, and so forth, it's a global enterprise. It's a global ecosystem. So when we have, let's say, and we have three challenge areas that we have prioritized: infectious diseases, mental health, and climate and health. And in particular, in infectious disease and mental health, we are focusing on supporting science to develop new solutions. And then we set in a way, we look at the global ecosystem, we look at the needs, we look at the portfolios, and we see what other funders are doing, and then we prioritize where can we make a difference. So with schistosomiasis, leishmaniasis, arbovirus, vector-borne viral diseases, antimicrobial resistance, just to mention some within the infectious disease space. And the problem then, and that is rational, because it's rational from a global point of view. But then we fund centers. The reason I was in Malawi, we support a large research center in Blantyre, similar in Kilifi, similar in KwaZulu-Natal in South Africa. And they, of course, they see the local infectious disease challenges. They want to do applied research that are really addressing the needs of their communities. And how do we negotiate that in a way? And that's where it's a trade-off and it's a dilemma. So what we try to do is, in a way, we need to have open schemes and calls where they can define the needs based on discussions with their local governments, and then come with applications, and we build that into our core support. But there's still a need for also that global perspective. But definitely the Lusaka Agenda is more about also equitable partnerships in research. We have made a decision to gradually increase our portfolio funding directly research in low- and middle-income countries, and not through academic institutions in the global north, and so that, but the researchers in low- and middle-income countries can partner, but they need to define and identify their partners and be the core sort of leaders on programs. But this will take time. It's a gradual transition.
Adis, you want to jump in here?
Yeah, I just want to talk a little bit about the sovereignty thing, because it needs to be the mood in the air at the moment. So at the continental level, the African Union has launched the Health, Security and Sovereignty Agenda, which basically signals a huge drive towards self-reliance. So it's an important thing to have. But my concern is, sovereignty has to be matched with commitment. It has to be matched with accountability. Because in 2001, we had the Abuja Declaration, and it's been how many years now? 20-something years. Only 3 countries in Africa have basically achieved or exceeded this commitment. More than 30 countries are still allocating less than 10% of their national budgets to health, and some are basically doing something between 5 and 7. So we can have commitments, we can have declarations after declarations, we can have lots of things, but unless those things are matched with accountability and real commitment on the ground, it doesn't really help. And also, we're talking about local manufacturing. It's important. Africa needs to have its own local manufacturing capacity, whether it's medicines, vaccines, diagnostics, whatever, essential medicines or so. Where are we now? We've been talking about local manufacturing for the last several decades. Where are we now? We're importing more than 90% of the medicines, the diagnostics, vaccines from overseas. So we need to have we need to move forward with some concrete steps. I think we've had enough commitments, declarations, and so on. Now it's time for action.
Yeah, that's great. Calypso, what is your perspective on the sovereignty issue? How are you seeing that play out from your interactions with countries at WHO?
I think it's a very real movement, and it's great to see senior leadership across Africa sort of state these things. I mean, as they said, we've had these declarations for a while, but now seeing, again, at the presidential level, even it's not just ministries of health, and it is presidents of nations coming forward and saying, we want to drive our own priorities and we will invest and all of that. So I think that's important. I think this is the time where we need to start seeing action, as you said, and in my mind, action is budget allocations, one of the proxies, right? So looking to see whether governments are indeed increasing allocations to health, whether they're taking measures to improve efficiencies. Yeah. If they want to exert industrial policy because they want to produce locally, are they doing that? What's happening to AMA and other mechanisms, the free trade area across Africa? So what are the movements that countries are making towards improving trade conditions, tapping into their own sovereign wealth funds to invest in health, education, human capital? And these are things that can be measured, right? It's not like they're not apocryphal. We can see whether they're doing them or not. So this is the time that we should be seeing those shifts happen, and the jury, I think, is still out. But I think having the statements to start with is important, and it's been a bit of a wake-up call, right? I mean, the latest shock in terms of the cuts, the sudden drops in aid, people realizing that they're not in control of this money, even less than perhaps they thought they were. And so I think that's not, well, let's see.
Yeah, let's see.
Yep.
Yeah, go ahead.
Yeah, I just wanted to make one balancing sort of statement to what I said before. I mean, there has to be that commitment, matching of accountability and everything. I keep on reiterating that, but what fiscal space are they basically playing with? Yeah. So in Ethiopia and across much of Africa, the fiscal space is quite tight, very, very tight, because of rising debt, the debt pressures, competing priorities, and lots of other things, including like the illicit financial outflows. Debt, if you, for example, take the debt in 2025. The Africa debt service amount was $81 billion. Actually, way higher than what it it basically received that year from external sources. And then if you take the illicit financial outflows, it's very significant. For example, in my own country, Ethiopia, where in 2023 it was like 1.5 to $2 billion, through base erosion and profit shifting. So there is a bigger problem around the size of the pie.
Yeah.
The size of the pie is still very, very, and it's very, very crowded. So we're basically asking more from that already, very, shrunken pie. So countries need to take some real actions in terms of how they could expand, this pie through, improving their, tax administration and policy measures, and also negotiating on the debt front, something that the global community has to do, something about. The illicit financial outflows, which is basically eroding, the continent in lots of ways. So I just want to make that balancing, sort of.
So it's so important, and I think even the illicit financial flows are even being normalized and legalized in some of these bilateral compacts that the United States wants to sign with different African governments, trading mineral rights for ODA. So they're just making that more plain, but it will still have a profound impact on countries. And I know there's some countries like Zambia that are saying, we're not so fast with that, trading our sovereignty and our mineral wealth. So, Jan Arne.
But this is not new, because
No,
in a way,
it's naked.
it's been for decades. And again, this is also a responsibility, of course, for national decision makers, because natural resources, oil, gas, gold, critical minerals, the economy around that has been heavily concentrated in many countries in Africa as well. So, and there are local nationals, politicians, that have benefited extremely. Corruption and but also the way the tax system and the way it's structured. So the illicit flows are not only bad actors coming from the outside, it's actually really bad actors from the inside, and the lack of accountability to that. So it's of course, it's a democratic challenge. It's an accountability challenge. I would just want briefly to also, given we were on the research agenda, I see what we have not done sufficiently in the past is to try to engage with local governments to establish research investments. Because in a way, it's easy to say, okay, governments first need to invest in healthcare, and until they have reached a certain level of development, they shouldn't invest in research. But I think that's flawed. I think it needs to be done in parallel.
Simultaneously.
Exactly. And we have not had good sort of dialogues with governments necessarily. We have funded from afar, really, and individual institutions. We are now in Southeast Asia establishing a collaboration with the ASEAN countries, and we are looking into more co-financing opportunities. With the government of India, we have a great collaboration. They now fund 2/3 of the cost of the program. We fund 1/3. So building up that capability alongside, of course, domestic financing. And this is linked to the manufacturing agenda.
Yes.
So it is, the manufacturing agenda is high, and I understand why. It creates jobs, it creates like economic systems, so health is then not only an expenditure, but it's actually a part of the economy.
Resource.
But in a way, as I mentioned briefly, it's unfortunate that it became the vaccines and that became the poster child for this, because it's the hardest commodity to produce.
Yeah.
I closed the last sort of commercial vaccine manufacturing facility in Norway. So there's no vaccine manufacturing in Norway, among the richest countries in the world. If you look at the European countries, there is only a minority of European countries that produce vaccines. And still, presidents in Africa, they all want their own vaccine manufacturing facility. That's irrational.
That's irrational.
It will be a lot of sunk costs and sort of investments that are not used. So how can that agenda be driven towards, other commodities?
And you think the less complicated would be like essential drugs or something? I mean, you're not saying no manufacturing, you're saying not the,
Yeah, and like many other countries, you import API and produce locally, and then gradually start producing API, active pharmaceutical ingredients, and do fill and finish on vaccines, gradually maybe start with some antigens and concentrate it in just a few countries. I think that's the only long-term viable. We hope now, we fund the large TB vaccine trial together with the Gates Foundation. more than 20,000 enrolled. We hope the results will be ready and positive in 2 years from now. That is a good example of a vaccine that should, at least part of that production should be done in Africa and in Southeast Asia with the biggest burdens of TB. So how can we use those new, instead of all countries wanting them mRNA facility, and then the only mRNA vaccine that is approved is COVID, and the need of COVID vaccines is plummeted. So.
That's where there's potential through the vertical funds, for instance, to shape the market and buy local, right? So you have demand that's at least for a few years guaranteed. So that's an incentive for DFIs to come in and invest, and companies to step in and so I think that's an opportunity there. But I want to just on the question of solidarity, I think it's quite important to remind ourselves that solidarity is about risk pooling. And it's not just, when I was talking about the sort of broader economic system, it's not charity, it's corrective action. When governments after the Second World War got together and set up the IMF, Bretton Woods, they were looking at that solidarity because it was beneficial to all. They agreed that that we all need to grow, all economies, and we've lost that. And it's now become about, it's become extremely fragmented in so many different ways. We now talk about regionalization, but you don't want regionalization when it comes to financing. You don't want Africa to be on its own, and you want Europe to be on its own, North America. You want these broader risk pools because that interdependence actually is a good thing. And you want, in a sense, markets. You want people to become wealthier to be able to consume. And that's not like a Marxian argument. This is pretty a market-oriented argument. We need to remind ourselves that that's what we should be talking about. And yet what we're seeing now is that MDBs which step in to support countries in distress or near distress end up underwriting and servicing private lending. And so Africa has become the biggest creditor to the world. So that's the sort of the exorbitant privilege, right? There's a strong empirical evidence that shows that a large amount of money leaves Africa and goes elsewhere. So and yes, of course, when it comes to governance and all of these things are important, but I think it's important to talk about, even from a self-interest perspective, about risk pooling, about sharing responsibilities. And to a very, very last point I want to make on health. And I think it's also important for organizations like the World Health Organization, people who work in health, to talk about the economic and social returns of investing in health. And again, we sort of lost that a little bit. And it's important, language does matter, and we need to remind ourselves. And these are resolutions and commitments that were voted in the 70s. It was very clear. The PHC resolution, Alma-Ata, openly talked about social development, about economic development, and how it's important for people to be healthy.
And our shared responsibility globally.
Exactly. And I think we need to return to that language, remind ourselves a little bit why, I mean, after all, you know, it does matter.
Yeah, great. Adis, would you like to talk
just
about sort of solidarity?
Solidarity, yeah. So I think probably from now on, we have to, solidarity somehow has to move from rhetoric to choices. And for me, solidarity should be anchored on three important things. One, alignment. Second, equity, and third, efficiency. On the alignment, you know, we've talked about it. It's like supporting the country's priorities, making sure that, you know, whatever we do is not disrupting systems or creating any parallel systems. And on the equity front, protecting the most vulnerable, as Professor Ola, you know, put it at the beginning, protecting the most vulnerable and prioritizing the high impact, you know, services, especially at the primary healthcare level, particularly in Africa. And third, the efficiency, ensuring that, you know, we're delivering the maximum value for every dollar that we're investing in our health system. So I think when budgets are sort of shrinking, solidarity is not about adding more. It's more about how we allocate what basically remains in our hands.
Yeah.
So Sanja mentioned this briefly, but I think an important tool, and I think it's a good opportunity to do it now. It's really to take a relook at the OECD DAC rules on what counts as official development aid. And there are different views on this, but I'm of the held view that we should differentiate, as Sanja also said, solidarity in a way, so support to individual countries where where we want to support from an enlightened altruism or self-interest in some way, and the public goods. And given that the 0.7 target is now so off, it's sort of no country except my own country, Ole's country, we are still at 1%.
Go Norway!
But we are benefiting from the wars in the world. So just to take down that self-image, we should actually differentiate. So take out the first-year migration cost completely out of the picture, have a solidarity component and a clear global public good component, and then do advocacy for. Still, the world needs solidarity, but then we need efficiency as well. And the global health aid system has been expensive. And I think so. Minister Pate from Nigeria has said on the stage, and therefore I can say it many times, that they believe they can deliver the HIV program at 40% of the cost of the former program that was very sort of bypassing programs and funded externally. The challenge is the transitioning, because pay scales are 2, 3, 4 times higher in those programs, and the same is in South Africa. So when the government needs to take on this, you have a big movement of people who have been used to have salary levels that are higher than in the normal healthcare system. And how do you reconcile that? That's hard. It's hard for those individuals, of course, but it's also hard for the system. So we need to be much more accountable when it comes to how we do align with country systems and levels and support in a truly solidaric way.
And just to say, as the only American on the panel, I mean, a lot of the way U.S. has given aid has bypassed governments, has gone to NGOs, has gone to sort of these trainings and per diem economies that really did not, help people. So
but it's not only the U.S. It's our collective instrument through the Global Fund is another definitely doing the same, and a lot of European bilateral aid is doing this as well. And it's a big aid industry where people fly as consultants in and out, and as some. And the pay levels in Geneva are also quite high.
Calypso, he's talking to you.
And they don't pay tax even, so how should we...
Where's the welcome trust legacy? Let's look at the history of the welcome trust. Exactly. And now the next step, we're going to fight here on.
Well, I am just delighted that we had such a spirited discussion, right? I mean, I think these are very unique perspectives, and I think as we think about our way forward, bringing people to the table with very different opinions, some similar opinions, different experiences is so important, and to really hash these things out together. I'm grateful for all your honesty and integrity, bringing your true voice and true opinions to this discussion. So thank you all so much. We may have time for 1 or 2 questions.
Thank you.
Yeah, Ali Yeaman.
So thank you very much for a really provocative and thoughtful discussion. It strikes me that there's, you've all in many ways identified the same fundamental issue, which is that you can't have health sovereignty without political sovereignty, which you can't have without economic sovereignty. And all of the structural conditions that limit that for many, many countries across the world. And yet when it comes to solutions, the global health community falls back on pragmatic tweaking here and there. And there's no wonder that this global health community is constantly criticized for sort of taking managerialist approaches to egregious inequalities and injustice. So is there a way to move beyond that with much more dramatic and bold interventions that we could, and we have a lot of people in the room representing governments, important institutions. Thank you.
Anybody? Yeah, go ahead.
I think the Financing for Development conference, for instance, and the consensus reached in Seville is an interesting first step where it positions financing for SDGs, specifically for health in the broader context. And there's some recommendations, some actions we're seeing, though not deeply radical, but for instance, looking at how to use special drawing rights in a different way, looking at how to boost local currency markets in countries, and regional development banks do lend in local currencies because that's a big issue. Or looking at debt, addressing the debt and debt servicing and the cost of debt, risk perceptions, credit rating agencies. So I think that's all important. It doesn't mean we shouldn't keep the focus on health, but the health community is quite impotent to some extent because we're not that plugged into that other conversation. And I think conferences such as this or movements such as this are more helpful than ourselves talking to ourselves. And that's why I think the Accra Reset and the latest drive from African presidents, the fact that you have the president of a nation or multiple nations actually using health as a spearhead and saying, well, actually, we do care about health at this point in time, and we do care about these economic and structural injustices, and we want to change the equation, including on illicit financial flows and trade, terms of trade, etc. But using health in their language and their narrative as the entry point, that's encouraging. But now we need to see what comes of it, and we don't have, a lot of time, and it could be that not much comes of it, it could be that things do change. But I think bringing those communities together and framing the domestic health financing conversation in the broader macroeconomic context, I think is an important starting point.
Okay, I don't think we have any time for more questions, but I want to thank you all so much.
Thank you. Thank you.